Very good afternoon to all of you, and welcome you all for the clinical combined round presented by Department of Hematology. So, the first case for CCR, we have a very interesting case and discussions. I would like to invite Dr. Mukul give the introduction of the case and subsequently other residents to present the case. Thank you.
Good afternoon, everyone. So we are presenting a very interesting case who presented to the dermatology department around a few years back and then had some complication and landed with us. So we'll be discussing about both the complication in this CCR. We have Dr. Ayush, who is our DM Clinical Hematology Fellow, Dr. Shashant, who is our DM Hematopathology Fellow, and Dr. Shashant from Dermatology, who will be discussing the various aspects of this case. So I hand over to Dr. Ayush to start with the proceedings.
Good afternoon, everyone. I'll be starting with the first case of today's CCR. So we have a patient, Mr. AK, a 34-year-old gentleman, resident of Haryana, who was an accountant by occupation. He presented to us with the chief complaints of mucosal bleeds and petechiae since the past 2 months, easy fatigability for 1 month, and fever for 1 month. He did not have any significant personal history, and there was no similar family history in the patient. He was apparently well 2 months back when he developed spontaneous nose and gum bleeding and petechiae over the bilateral lower limbs. These were not associated with any history of trauma. There was no associated hemarthrosis or deep muscle bleeds. For this, he was evaluated in an outside hospital and was started on oral steroids and injectable romiplastim. He failed to respond to this treatment. Over the next 4 weeks, he started developing other symptoms in the form of progressive easy fatigability, on and off undocumented fever, which was not associated with chills or rigors. He also has a pretty significant background history in the form of a skin disease in the past, with an approximate onset 7 years back at the age of 27 years, in the form of a non-pruritic brown-colored papular rash. This rash was initially present over the face and gradually progressed over a span of 5 years to involve the entire body with a flexural predominance. This is the photo of the rash in the patient. Associated symptoms, he had history of increased thirst, history of increased urine output, which was, however, not quantified, and progressive dyspnea associated with hoarseness of voice, for which he required a temporary tracheostomy. For all of these symptoms, he received some treatment in 2024 in the form of tablets and injectables, followed by resolution in all the symptoms. Examination on current presentation did not reveal much except pallor and petechiae, which were present over the trunk and bilateral lower limbs. Systemic examination was grossly within normal limits. There was no lymphadenopathy, liver and spleen were not palpable, and the rest of the systems were unremarkable. So at this point, on first glance, the current presentation looks like immune thrombocytopenia, which failed to respond to standard therapy. The current presentation can be primary hematological problem or maybe secondary to the previous dermatological condition. The progressive symptoms, however, suggest that something else is going on. Anemia and leukopenia might be present, multilayer cytopenia might be present because he had other symptoms such as fatigue and on and off fever as well, which are not explained by ITP. So the differentials at this point would be aplastic anemia, which would explain symptoms of the other lineages, but against the factor which is against aplastic anemia is usually such patients have pancytopenia from the onset. Acute leukemia again would explain symptoms of all the lineages. Bone marrow infiltration would also explain symptoms of the other lineages. However, there was no lymphadenopathy or hepatosplenomegaly in our patient. Coagulopathy would explain the bleeding phenotype, but the bleed was more like a platelet type bleeding and it does not explain the progressive symptoms. I would like to invite Dr. Sushant, senior resident from dermatology, for the elaboration of the skin findings.
So this gentleman had presented to us for about 5 to 6 years with these progressive skin lesions. These were brown, well-defined, coalescing to discrete papular skin lesions, coalescing to form plaques, mainly on the flexural sides and the periorbital area as well. He also had associated dyspnea requiring tracheostomy tube in situ, with which he had come to us from outside. We did a skin biopsy from these lesions and it revealed epidermal atrophy and dense band-like infiltrate in the superficial dermis. This infiltrate was predominantly composed of foamy histiocytes along with occasional giant cells of two-tone type. On IHC, these histiocytes were CD68 positive and negative for Langerin and CD1A. He also had complaints of increased thirst and increased urination, and on investigation, he had decreased serum and urine osmolality. On MRI brain, he had absent pituitary bright spot, confirming diagnosis of central diabetes insipidus. On fiber optic laryngoscopy, there was difficult visualization of the epiglottis and bilateral arytenoids because of presence of xanthoma lesions in the endolarynx as well. So connecting the background with the current presentation, he had involvement of bone marrow, skin, pituitary gland, and respiratory system. The possibilities that were considered were infectious, such as tuberculosis, or atypical organisms, such as atypical mycobacteria, fungal infection, but there was no predisposing condition for the patient to have these infections. Autoimmune or vasculitis spectrum could definitely be considered. Malignancy with paraneoplastic features was also considered, but the long history goes against this diagnosis. And infiltrative lesions were at the top of the differential list, including IgG4 diseases, sarcoidosis, and histiocytosis. The current hematological presentation may be due to the underlying baseline disease or the treatment received due to this primary skin disease or an independent event. Considering the involvement of skin in form of generalized brown papular non-pruritic rash, central diabetes insipidus, the shortness of breath with infiltrative lesions over the arytenoid and epiglottis, and CD68 positive histiocytes on histopathology, we made a diagnosis of xanthoma disseminatum. For this, he had initially received treatment with imatinib, dasatinib, and steroids from outside with no response. So we initiated him on cladribine 0.14 mg per kg per day, given over 5 days in a month. With six cycles, he had considerable improvement in the skin disease and respiratory symptoms as well, and we were able to take out the tracheostomy tube. However, the central diabetes insipidus did not respond, and he required continuation of desmopressin therapy. Now I'll invite my colleague from hematopathology to take over.
Good afternoon. Continuing with the case. On laboratory evaluation, we can see from the table that there is progressive anemia, leukopenia, and thrombocytopenia, that is pancytopenia. However, other biochemical parameters were within normal limits. These pictures are the microscopic images of the peripheral blood smear. The peripheral blood smear had pancytopenia, around 8% blast, which we can see these large cells. And many of these blasts had prominent cytoplasmic granules. However, there were no R rods or faggot cells seen. We also received bone marrow aspiration of this patient. From the images, we can see that the bone marrow is particulate. However, the particles are excessively cellular, that is hypercellular, and the bone marrow aspirate showed almost monotonous population of these blasts. We can see from the lower row of images that these blasts are abundantly granular. However, no faggot cells were seen. On cytochemistry with myeloperoxidase, these blasts were strongly positive. We also received bone marrow biopsy of this patient. We can see from the images that the bone marrow biopsy marrow spaces are hypercellular with an approximate cellularity of 80%, and the marrow was completely replaced by this monotonous population of blasts. We proceeded with the bone marrow aspiration flow cytometry, and we started with the screening with the acute leukemia orientation tube to get an idea about the blast, whether they are myeloid or lymphoid. From this plot here, CD45 against the side scatter, we can see there is a large chunk of cells sitting in the dim CD45 versus intermediate to high side scatter region. On further characterization, these blasts were dim to negative CD45 in expression. However, they showed a strong myeloperoxidase expression. Other antigens for B lymphoid and T lymphoid were negative. We further proceeded with the characterization of these blasts with the AML1 myeloid tube. From these plots, we can see that these blasts are showing bright expression for CD13 and again bright expression for CD33, heterogeneous expression for CD117, and dim expression for CD34, dim for CD123, and moderate positivity for CD38. However, these blasts were negative for CD11B and HLA-DR. So at this juncture, we are sure that these are myeloid blasts. Further, these flow cytometric plots are of the AML2 tube, which we do for to look for the expression of the blast for monocytic markers. These blasts showed dim to moderate expression of CD64. However, they were negative for CD14, CD56, and CD7. So at this juncture, we have an immunophenotypic diagnosis of acute myeloid leukemia. These are the reports of the conventional karyotyping, and we can see at the bottom, you can also see the NGS report of this patient. This patient did not show any adverse cytogenetics. This patient had trisomy 8 and a monoallelic SEPA mutation. Apparently, it seems that the patient has a favorable mutation. However, the mutation was not in the B-zip region. As per the ELN 2022 criteria, this patient falls in the intermediate risk, being AML with trisomy 8 and SEPA mutation in the non-B-zip region. Coming to the diagnosis, the baseline diagnosis was xanthoma disseminatum with diabetes insipidus and laryngeal involvement. This patient received cladribine therapy, and the current diagnosis is acute myeloid leukemia. Now I invite Dr. Ayush to continue with the discussion.
So reiterating the final diagnosis is xanthoma disseminatum with diabetes insipidus and laryngeal involvement, for which he received cladribine, and the current presentation is acute myeloid leukemia. So I'll be briefly discussing this case under 3 subheadings: histiocytosis, xanthoma disseminatum, therapy-related AML, and management of these secondary AMLs. This is a schematic of the mononuclear phagocyte system, which has multiple cells. These cells can be classified primarily by their ontogeny, which is their cell of origin, and secondarily by their location, function, and phenotype. So any cell which is of an embryonic origin would be a macrophage, and cells from an adult hematopoietic stem cell origin would be either a monocyte or a dendritic cell. And Langerhans cell is a specific type of a macrophage which resides in the skin. Histiocyte is another term. Histiocyte is another term which is an overarching morphological or histopathological term which includes macrophages as well as dendritic cells. So histiocytosis is a broad group of disorders which has 2 broad classifications. One is the Histiocyte Society classification of 2016, which classifies these disorders into 5 groups: L, C, M, R, and H. The L group contains Langerhans cell histiocytosis and non-LCH disorders like Erdheim-Chester disease as well. The C group is cutaneous non-LCH histiocytosis. M group contains malignant histiocytosis, which can be primary or secondary. R group is Rosai-Dorfman disease, and the H group has HLH, both primary and secondary. There's another classification from the WHO 5 2022, which only classifies malignant disorders. Not all histiocytoses are malignant. Coming to xanthoma disseminatum, it is a rare normal lipemic mucocutaneous xanthomatosis, which is characterized by proliferation of histiocytic cells and secondary deposition of lipid in the dermis under the broad spectrum of non-Langerhans cell histiocytic disorders. It is classified under the C group of the Histiocyte Society 2016 classification. The clinical features: it is a very rare disease with less than 200 or odd so cases reported worldwide. The male to female ratio is approximately 2.4:1. It usually has a childhood to young adult onset, and most of the patients present with both cutaneous and systemic involvement. The cutaneous features are usually multiple symmetrically distributed yellow-brown papules and nodules with a flexural predilection. The exact same presentation was seen in our patient. Systemic involvement is also fairly common. It can be seen in the form of mucosal lesions in the larynx and oral cavity. Then CNS involvement in the form of pituitary stalk infiltration or pituitary infiltration is common and is seen in up to 40% of the patients, and our patient also had this. Rarely skeletal lytic lesions and mucosal ocular lesions can be seen. The pathogenesis, the pathophysiology is poorly understood. Rare MAPK pathway mutations have been reported, but no one knows for sure what causes xanthoma disseminatum. The diagnosis, for diagnosis, since it is such a rare disease, there is no absolute criteria, but the diagnosis is made by taking into account all the modalities that we have. So it is a clinical presentation plus lab part plus histology and the IHC. Biopsy is mandatory for the diagnosis and usually demonstrates foamy histiocytes, multinucleated giant cells, and two-tone giant cells, of which a representative image is given. Then IHC clinches the diagnosis in these patients. So in IHC, we can differentiate between non-LCH and LCH type of histiocytosis. 2 to 3 markers are there which help us differentiate these disorders. CD68, number 1, is strongly positive in non-LCH and only weakly positive in LCH. And number 2 and 3, CD1A and CD207, which is also known as Langerin, it is positive in LCH but negative in non-LCH. So according to this IHC criteria, our patient fit the non-LCH disorder. Treatment, we have physical treatment approaches in the form of surgical removal, CO2 laser, pulsed dye laser, narrowband UVB. All of these are physical treatments only. They do not prevent new lesions. They do not target the underlying pathophysiology. And they're mostly used as cosmetic procedures or adjuncts. Then lipid lowering therapies can be tried even if the patient is normal lipemic with a normal serum cholesterol, normal total cholesterol, in the form of statins and fibrates. Then immunosuppressive treatment, we have a variety of drugs. Mostly the evidence is in the form of case reports and case series in the form of steroids, azathioprine, anakinra, which is an IL-1 antagonist, interferon gamma. And the mainstay of therapy is cytostatic-based therapy, in which the best evidence we have is for cladribine, followed by TKI, imatinib, dasatinib. Isolated case reports are available, then cyclophosphamide and etoposide. This is a paper on long-term therapeutic outcomes with cladribine in patients with xanthoma disseminatum from our dermatology department in AIIMS, Delhi. They had a case series of 6 patients, most of whom had cutaneous and systemic involvement. They received monthly cladribine cycles with a median of 6, and mean skin improvement was 63% at the end of therapy and 75% at 2 years follow-up. So the patients continued to improve even after cessation of therapy. There was 1 relapse seen in these 6 patients, and the main toxicity was transient myelosuppression in the form of leukopenia. Now, coming to the link between xanthoma disseminatum and myeloid neoplasia, evidence shows that there is a biological association between histiocytic disorders and myeloid neoplasms. There's an increased frequency of myeloid neoplasms in the non-LCH group, up to a prevalence of 10%, which is fairly high. Shared somatic mutations between histiocytosis and myeloid neoplasia have also been documented. This is a paper published in the journal Blood in 2017. It enrolled 189 patients with AIIMS Chester disease only, and it was seen that 10.1% of these patients had concomitant myeloid neoplasia in the form of either MPN, MDS, CMML, or AML. And those with myeloid neoplasia were usually older and had a worse overall survival. One explanation for the older presentation in concomitant myeloid neoplasia is that there is acquisition of mutations with age. This is known as clonal hematopoiesis, and this can lead to clonal evolution and ultimately lead to a leukemia. So this diagram just shows that one single cell has a mutation that is a clonal hematopoiesis. This can progress and lead to a full-fledged acute leukemia. So this data is in AIIMS Chester disease. Our patient is xanthoma disseminatum. For xanthoma disseminatum, there's only 1 case report that I could find for a patient with concomitant AML. This particular patient was a 59-year-old gentleman who presented 4 years, who had a xanthoma disseminatum clinical features 4 years prior to the AML diagnosis. In this patient, the AML was RUNX1 mutated, placing him into the adverse category. And the implication is that xanthoma disseminatum may precede or signal an underlying myeloid malignancy. So the clinical implication from the link between histiocytosis and myeloid neoplasia would be that in any case of non-LCH or xanthoma disseminatum, however rare it may be, you have to monitor serial CBCs on follow-up. And any CBC abnormality or unexplained cytopenia requires a prompt, detailed evaluation, including bone marrow examination with morphology, flow cytometry, and genetic analyses to diagnose any underlying myeloid neoplasia. You have to maintain long-term surveillance because myeloid neoplasia may develop years after the skin disease. Coming to briefly about the therapy-related AML also. Therapy-related AMLs are associated with a shorter survival than de novo AML. This schematic shows the evolution from a single clone to multiple clones of acute myeloid leukemia, just to demonstrate that clonal evolution in AML is kind of like Darwinian evolution. Multiple clones can form, these clones can interact with each other, they can compete with each other. And therapy, any prior therapy like ionizing radiation or DNA damaging agents can act as a selective pressure for emergence of resistant clones. The diagnosis of therapy-related AML is based on the history of receipt of previous DNA damaging agent or radiation. And WHO5 and the international consensus classification use different terminologies for this entity. WHO5 calls it post-cytotoxic therapy and ICC calls it therapy-related. Most of therapy-related myeloid neoplasias are associated with adverse genetic lesions because of the selective pressure that they exert. More than 95% have an abnormal karyotype like monosomy 5 and monosomy 7, which fortunately was absent in our patient. SEPA isn't a common mutation in therapy-related AML. The common mutations are given in the graph below. Most commonly, TP53, PPMD, FLT3 are seen, and the worst prognosis is with TP53. The common agents leading to therapy-related AML, they include alkylating agents and topoisomerase inhibitors. The examples are given. Antimetabolites such as cladribine are very, very uncommonly related to secondary myeloid neoplasias. And then other agents like antitubulin agents, PARP inhibitors, and ionizing radiation is also there. One case, post-cladribine AML is again not very common and not a very typical cause of secondary AML. One case series that I could find was of this, which showed like the denominator you can see in the second column, 928, 1022. Out of these, only 8 cases were developed AML after hairy cell leukemia treatment with cladribine with a variable time lag. So just goes on to show that the disease is not, cladribine is not a very common cause of secondary AML. Treatment of secondary AML, in our setup, it usually depends on whether the patient is fit or unfit. In unfit patients, we use lower intensive chemotherapy like azacitidine, venetoclax, and in fit patients, we use intensive chemotherapy in the form of 7+3. In the Western countries, there are additional agents that are available specifically for therapy-related AML, one of which is CPX351, which is a liposomal combination of daunorubicin and cytarabine. Unfortunately, we do not have this agent in India. The common link between all of this treatment is that whatever way you use, whether azacitidine, venetoclax, or intensive chemotherapy, the final common thing has to be an allogenic stem cell transplant, provided, of course, that the patient has a donor and the logistic requirements are met. So a hypothesis in our patient would be that he already would have had a baseline predisposition to myeloid neoplasia due to an underlying stem cell defect in histiocytosis. And exposure to cladribine may have acted as a selective pressure causing expansion of a leukemogenic clone. This is just one hypothesis. We cannot confirm or refute this. Coming back to a patient, he was diagnosed as AML with the risk stratification of intermediate risk according to European Leukemia Net guidelines. He was started on 7+3 chemo induction, which is an intensive chemotherapy. End of induction bone marrow showed complete remission. The further plan for this patient would be to consolidate with further cycles of chemotherapy followed by an allogenic hematopoietic stem cell transplant. The take-home points would be that xanthoma disseminator may involve organs other than the skin. It has systemic involvement. Non-Langerhans cell histiocytoses can be associated with myeloid neoplasias, as already demonstrated. Unexplained cytopenias or CBC abnormality in histiocytoses require urgent evaluation. Cytotoxic drugs, including purine analogs, can lead to secondary leukemia, or albeit rarely, and multidisciplinary care can improve outcomes. Thank you. I invite Dr. Neetu from dermatology and Dr. Mukul from hematology for their expert comments.
Thank you, Dr. Ayush. So, xanthoma disseminatum, as Dr. Ayush and Dr. Sushant discussed, is a rare form of non-Langerhans cell histiocytosis. We see 1 to 2 cases per year. And majority of these patients are young adults. Sometimes we see children, sometimes we see in 40s and 50s as well. Most of the time, these patients are severely morbid because of the systemic associations of the disease. So, though the literature showed 40% diabetes insipidus in our cohort, it was present in almost everyone, 5 out of 6, so 83%. So, they have diabetes insipidus, they have significant laryngeal involvement, there is CNS involvement, skeletal involvement was also there in 50% of our cohort, so osteolytic lesions were there. So, they are in a morbid condition. Before 2017, we were treating them as discussed with immunosuppressive therapy, so oral steroid, cyclophosphamide, azathioprine, with variable improvement. Since 2017, cladribine was used initially. We saw a 1 or 2 case report and we started using it. And our indication was never the cutaneous involvement. Our indication was severe systemic involvement. So children or young adults presenting with a tracheostomy tube because of severe laryngeal involvement, CNS involvement, osteolytic involvement, with the help of medical oncology team, we started giving them cladribine therapy. Initially, because we read and we were overcautious, we were giving them, and even now, Septran, acyclovir, prophylaxis, and continuous GM-CSF therapy for 5 days because transient transient bone marrow suppression is a known side effect. And these patients, we noted very significant improvement in the systemic morbidity. Skin was still showing a modest improvement, but their laryngeal involvement was showing significant improvement. A child who had severe optic nerve atrophy, he showed improvement in the vision. So systemic complications showing better response. Cutaneous lesions are also showing modest to good improvement. One patient who had relapse in that series also showed good improvement with a second course of infusion. So as we discussed, the bone marrow suppression is a known side effect. In 50% of them, we found there was transient leukopenia, which improved on subsequent to just monitoring. In this young adult patient, he also had transient leukopenia. It improved and we were relieved, but then he had a recurrence of thrombocytopenia and associated symptom, for which I think the hematology team and hematopathology team did an excellent job in reaching to a correct diagnosis and treating him in the correct direction. Thank you.
Thank you, ma'am. So I'll just briefly talk about secondary AML, which was the condition present in this patient. So both the xanthomatous diseases or histiocytic disorders can predispose to secondary leukemias. We use cladribine a lot for our hairy cell leukemia patient and have been using it for since since my DM days, almost 1.5 decade back. So it's been quite a lot time. As you can see from that series, it's a recent series, and only around 7-8 cases have developed secondary leukemias post cladribine. In our experience, till now, we have seen relapses of hairy cell leukemia, but no AML or myeloid neoplasm in these populations. Per se, whatever data with respect to secondary leukemias, chemotherapy related is there, it is with respect to alkylating agents, topoisomerase inhibitors like daunorubicin, doxorubicin, or even radiotherapy. So whatever high-risk features they are associated with the secondary leukemias are secondary to these class of drugs. Fludarabine and cladribine, they are nucleoside analogs. They are used for therapy of secondary for acute myeloid leukemias as well. So they are very commonly used for in the management of AML these days. Possibly in our case also, like Dr. Ayush said, cladribine might have been a contributor, but more likely it was the underlying disease process which led to secondary AML in this patient. The treatment for these patients is difficult in a way that they can have prolonged myelosuppression because of multiple reasons, and post chemotherapy, the chances of going into remission are slightly lesser than de novo AML. Most of the patients are to be consolidated with stem cell transplant, either a sibling or a haplo or whatever transplant you can give them. Still, with the transplant also, the long-term survivorship is in the range of only 30 to 40%. So that becomes a problem with respect to long-term survivorship. So, sir? Yeah, so that's it from our side. I'll invite questions and comments.
Including some genes. So there are few genes like but there is no particular, it is not Mendelian, but there is some family history with insuperability. And there is predilation toward this pituitary. It is a multisystem disease. So pituitary is a common site of infection, and that's why 90% of them have associated diabetes in pituitary. And your cladribine may improve your other signs and symptoms, but that will require lifelong dextrosectomy.
So we did targeted NGS for this patient, and no other, at least in the screen genes, no other specific genetic predisposition syndrome was found for this patient. So that's a part of our workup for all AML patients, and no specific genes were found in the screening. Yeah, maybe that's always a possibility. So there are no further comments. I'd like to thank our team, our lab team and dermatology team especially. Thank you, ma'am, and hand over for the next CCR. Thank you.